Siêu, dear Dr. Professor Nguyễn Ngọc Quang, and on the panelists and the audiences today. Welcome to our Rovers Club this afternoon. You know, nowadays, intravascular imaging is very important in PCI, especially PCI for complicated lesion, for example, bifurcation or Lehmann disease. Because of doing PCI for the Lehmann or bifurcation require optimize the procedure to minimize the MACE and TVR. So we need to use the devices, for example, IVUS or OCT or FFR to assess the lesion, to choose the trajectory for PCI, to sizing the stent, etc. So very important. How can we do this? The speaker today and the panelists will share with us the knowledge, their experiences in doing IVUS for bifurcation lesion. Come with us is Dr. Soiki Kuramitsu from Japan, Professor Nguyễn Ngọc Quang from Heart Institute of Vietnam, Dr. Nguyễn Thượng Nghĩa from Chợ Rẫy Hospital, Professor Nguyễn Văn Tân from Thống Nhất Hospital, Dr. Di Phương from Ho Chi Minh City Heart Institute, Dr. Trần Hòa from UMC, Dr. Hoàng Hoang from Hanoi Heart Institute, and Dr. Vũ Hoàng Vũ also in University Medical Center. Today, we have a lecture, Roles of IVUS in Bifurcation Lesion, and we have a case sharing and discussion. And we also have a live case from University Medical Center. I am sure that by these courses, we will have a chance to learn from each other and will become the operator who can use in IVUS in BCI for the bifurcation lesion. Finally, I want to say thank you to Dr. Soichi Kuramitsu and all the panelists here. Thank you to all the audiences today. And now, I would like to invite Dr. Kuramitsu to present your topic. Dr. Kuramitsu, please.
Thank you, Professor Ben. So can you see my slide?
Yes, I see it clearly.
Okay, good. So first of all, I thanks all of you to giving me the great opportunity to talk about IVUS guided PCI in bifurcation lesion. So today's my title is clinical role of IVUS in bifurcation lesion. And in my lectures, so we study IVUS guided PCI in bifurcation lesion with a case-based approach today. So first case is 80 years old male, so present with chronic coronary syndrome. The target region is bifurcation region in proximal LVD. So this is an angiogram. So as you can see here, so the region is proximal region, so with severe calcification. So however, so in the cranial view, so it's a little bit difficult to identify the target region. This is IVUS. So now septal branch is coming from 4 o'clock or 5 o'clock, and this is the target region site split is coming soon. So this is a diagonal branch. This is the most tightest point. High lateral branch and circumflex. So the most important point is, so how should we interpret this IVUS finding? So today, I'd like to make my lecture more interactive. So that's why I prepare a couple of questions. So, okay, thank you so much. So I'm not sure who managed this system. So anyway, so this is my first question. So how about your PCI strategy according to the angiogram and the IVUS finding? So just stenting with guide wire protection, and stenting with gel balloon technique, and others. Okay. The number 2, stenting with guide wire protection. So this around 70%. Second is a gel balloon technique. Okay, thank you so much. So first of all, I'm not the operator in this case, but the operator decided to put a stent with a guide wire protection to the maybe a high lateral branch. So this is the IVUS. So after stenting, so now septal branch is coming. So please look at the around 10 o'clock site. So diagonal branch will be coming. This is a diagonal branch. This is a high lateral and circumflex. So if you are familiar with IVUS, you can notice the diagonal branch is completely occluded. So once again, I will show you this IVUS pullback recording. So please look at the around 10 o'clock size. This is a diagonal branch. So this is an angiogram before and after stenting. So left side is before and right side after. So as you can see here, so big diagonal branch is completely disappeared, occluded. So, you know, side branch occlusion has a crucial impact on clinical outcome in patients with bifurcation lesion. So myocardial territory of side branch should be considered so when treating bifurcation lesion. So especially when the percent territory appears over 10%, so we have to keep it open. So recently, a Korean group proposed a novel criteria to assess the myocardial territory of diagonal branch. So according to the anatomical information of circumflex dominance and diagonal branch dominance and the number of branches. So we apply this criteria to this case. So I think this case is classified into this pattern, 2 branches, dominant D1. So in this pattern, you know, diagonal or branch territory is over 10%. So it means, so we have to avoid side branch occlusion. So to get a better outcome in this patient. So how can we predict the risk of side branch occlusion? The answer is so simple, IVUS. So here are my IVUS predictor of side branch occlusion. So there are 3 components. So one is the plaque characteristics and volume at the opposite side of side branch. Number 2 is plaque volume at the ostium of side branch. And the number 3 is angle between the main branch and side branch. So back to this case. So as already mentioned, so we cannot identify the target region site. So from a clinical view, so however, according to the IVUS finding, the 3 components are free met. And in particular, the angle between the main branch and side branch is so sharp in this case. So because we can see the both main branch and diagonal branch at some cross-section area, cross-section images. So it means the side branch runs parallel to main branch. Okay, so this is a key point to predict the risk of side branch occlusion according to the IVUS finding. So, you know, for preventing side branch occlusion, so we have some option. So guide wire protection, gel balloon, or crochet technique, and lesion modification. So using rotabrator, cutting balloon, or something. So about the clinical outcome. So after that, in this case, so of course, ST elevation so remains at the end of the procedure. The peak CPK was over 1,000. So however, he discharged post PCR 7 days. So, however, 10 days later, so he suddenly suffered cardiac arrest at home, being referred to our hospital. So as you can see here, so UCZ shows acute MO due to the anterior papillary muscle ruptures. So that's why emergent surgery is necessary to rescue him. So, this is actually nightmare case. So, however, we should recognize the clinical importance of IVAS guided PCI in bifurcation region. So, especially we should avoid side branch occlusion. So, when treating the bifurcation region. So this is the second case. So the patient is 70 years male, so present with CCS. So this is an angiogram. The target region is the very diffuse region. So from proximal to the mid LVD, there are another view. So because this patient asymptomatic, so that's why we check the physiological assessment before PCI. So this is a result of FFR probak recording. So, the for distal value 0.63, so positive. And so according to the FFR probak recording, so we should treat from proximal to the distal. So this is the IVAS probak from the septal branch. Okay. This is the diagonal branch. So, and you can see the superficial calcium. So from the proximal to the distal. This is the circumflex. Once again, so this is a septal branch. This one. And you can see the eccentric superficial calcium. So at the opposite side of side branch. Okay. So this is a summary of our finding in this case. So this is a diagonal branch. This is the target region site. So as I already mentioned, we can see the superficial and eccentric calcium at the opposite side of diagonal branch. And we can see the circumferential calcium at the proximal site. So, the limitation of IVAS is, so IVAS cannot detect the thickness of calcium. So however, if the stent view or stent boost is available in your catalabo, please use it. So so we can estimate the thickness of calcium using stent view or stent boost. So you can see the superficial calcium like this, okay? So this is the second question. So how about risk of side branch occlusion in this case? Okay, I already mentioned, so when considering the risk of side branch occlusion, so you should apply 3 components to your case. So one is the opposite side plaque characteristic and volume at the opposite side of side branch, and plaque volume at ostium of side branch, and angle between the main branch and side branch. So what is the answer? So answer is not yet coming. So I'm not sure who managed this system. So please, stop the polling and could you show us the answer? Okay, thank you. So, okay, so number one, probably, and the number two, maybe. Okay, thank you so much. All right, so once again, I will show you, my IBUS predictor of side branch occlusion. So here there are three components. So number one, so plaque characteristic and volume at the opposite side of the side branch. So yes, so we find large plaque burden with superficial calcium. So superficial calcium is a key point to predict their carina shift. Number two, no. Number three, yes. Okay, so among the three components, two components are met in this case. So that's why I think probably side branch occlusion occur in this case. All right, so next question. So how about your PCR strategy? So now, so we can estimate, so probably the side branch occlusion occurs in this case. So next is we should consider, so what should do, so next, okay. So number one, NC balloon dilatation, cutting or squaring balloon dilatation. Number three, rotablator. Number four, orbital atherectomy. Oh, so quick. Okay. Okay, thank you so much. So number two or number three. Okay, so thank you so much. So, so when the superficial calcium is found at the on the plaque, so at the ostium of side branch, so carina shift is likely to occur. So that's why, so when we see the superficial calcium at the opposite side of the side branch, so we should do optimal region preparation. So if you cannot do optimal region preparation, so carina shift is most likely to occur, resulting in the increased risk of side branch occlusion. Okay, so like this schema. So that's why region preparation is mandatory to reduce the risk of side branch occlusion. Sorry, already. Okay, so if you can do the optimal region preparation, so using rotablator, you can minimize the carina shift, preventing the side branch occlusion. So like this. So today I have not enough time to talk about rotablator use. However, how to decide the bar size? So we usually choose MLD plus 0.25 millimeter as a bar size. So if MLD is 1.25 millimeter, bar size is 1.5. So of course, we should consider several factors. And one is, for example, so we should draw a circle of bar size. So for example, we use the 1.5 millimeter bar, we draw a circle of radius of 0.75. And the wire bias is a key point to safely perform rotablator, and you can estimate the wire bias by assessing the location of IBUS caster. Okay. So that's why our strategy is rotablator with 1.5 millimeter bar in this case. So looking at this IVUS cross-section image, so IVUS caster does not attach the calcium. So that's why, so we should change the wire bias using extra support wire. So like this, okay? And also, if you control rotor bar rapidly, so bar is likely to jump into the distal, so leading to the risk of coronal perforation, so especially in eccentric region, so like this case. So that's why you should control rotor bar gently. Slow motion is better. And also, according to the IVUS finding, the IVUS caster attached to the healthy site as a septal branch. Okay, so that's why we stop the bar up to the septal branch. Okay, so like this. So this is the initial planning. So based on the IVUS finding. So this is a rotabrator. We perform 1.5 millimeter bar. So of course, we gently manipulate rotabrators. And we stop the burr so at the septal branch, so as initially planned. Okay, so this is the angiogram. So after the rotabrator, it looks okay. This is the IVUS. So as you can see here, so the superficial calcium is well ablated with 1.5 millimeter bar. This is a summary of IVUS finding before and after rotabrator. The calcium is well ablated with 1.5 bar, so like this. And also, so you can assess whether region is well ablated with rotabrator, so using stent views. So before and after stent view finding, so the calcium is become much thinner, okay? So like this. Okay, so after that, so we raise a lesion and we put the two stent. And this is a IVUS after stenting. So actually the stent is well expanded. And this is the diagonal branch. Diagonal branch, where is diagonal branch? Right. This is diagonal branch, okay. Okay, so after that, we perform KBI. This is the final angiogram. So we can obtain the good result. So even in the severe calcified eccentric plaque. Okay, this is the last case, okay? So last case is subtotal region. So my younger colleague tried to perform PCI in this case, but unfortunately the guide wire go into the subintimal space. So fortunately, the guide wire can pass into the side branch. So like this. So this is the IVUS, okay? So after crossing guide wire into the side branch. So actually, we can get distal lumen, and it looks okay. So once again, so main branch is coming from the 10 o'clock. This is the main branch. So however, guide wire cannot pass into the main branch, okay? So I was already showed the answer. So why guide wire cannot pass into the main branch. So, however, I guess it little bit difficult to identify the answer. Okay, so due to the limited time, so I skipped the discussion. So in this case, so guide wire takes a shortcut from intraplug to distal lumen. So actually, little bit difficult to identify the plug flap in the still image, but the plug flap cover the ostium of main branch in this case. So that's why guide wire cannot pass into the main branch. So like this anime. In this situation, the reverse guide wire technique is useful to get the distal lumen of main branch. So, I guess you already know this technique. So I skipped this anime, but anyway, so I usually use the double lumen caster and the polymer jacket guide wire. So like a Siêu block or Fielder FC. So in this technique. So 2 or 3 meter guide wire is advanced from the second lumen and just advance. This is a movie. So, okay, as already talked, so just advance this system. So back to the case, we try to get the distal lumen of side branch using reverse guide wire technique. So finally, we get the distal lumen. So like this. Okay. So key point is to appropriately interpret IVUS image. Okay. This is the IVUS finding after reverse guide wire crossing. Anyway, this is the final angiogram. So actually, the distal at the distal, the vessel become very spastic. So, however, according to the IVUS finding, there is no dissection. That's why we stop the procedure at this timing. Okay, so today's talk is over. So next webinar, maybe this is the last webinar, will be held on November 27th. So don't miss it. So this is a take-home message. So bifurcation region are one of the challenging regional subset. So even in the contemporary DS error. So when treating them, so we should take care of side branch occlusion associated with mortality. So, IVUS enable us to optimize the PCI strategy for bifurcation region. The prediction of side branch occlusion and appropriate region preparation based on IVUS finding are of utmost important to bifurcation PCI. So please note, this is a key point today. So 3 IVUS parameters for predicting side branch occlusion. So once again, one is plug characteristics and plug volume and the opposite side of side branch. Number 2, plug volume as the ostium of side branch. And last is angle between the main branch and side branch. Thank you for your attention.
Thank you, Professor Soichi Kuramitsu. With three interesting cases, you share with us the importance of the IVUS in PCI for the bifurcation lesion. We take the take-home message about how to avoid the occlusion of the side branch. Thank you very much. And next, we have a case sharing from Dr. Yi Phương from Ho Chi Minh City Heart Institute. I mentioned that if you have a question, we can put it at the end of the presentation, and after we finish the live case, we can have answer and question at that time. Thank you.
Yes.
Good afternoon, everyone. Today I have shared a case report from beside left main coronary. The patient is 64 years old male. He just chest pain 1 month ago. He come the hospital by heart value, EF is 25%, and dilated the left ventricle. Middle mitral valve recuperation. It's the ECG. The problem is the patient is low EF with ancient ischemic myocardiopathy with hypertension, diabetes. This is a medical therapy. Angiogram in 23rd April 2021. We see the occlusion in distal left main, but we see a little in L6, sub-occlusion L6. We see clearly a little contrast go to the ostium LED. We see again. RCA is bad, and the control from the RCA to the left control is the good control. And the stenosis in the middle of LED. Is now what should we do for the patient? Habit beside our optimal medical therapy. We stop this and discussion with my heart team. The syntax score once is 27. Is the syntax since we calculated the syntax score, error score for the patient. Risk the mortality of the patient is 2.1%. The patient have a diabetes, the low function, and the syntax score up to 23. For this patient should be the first choice is the cabbage. But after explain the patient and his family, they don't choose the cabbage. We refuse cabbage and we choose the BCI. After that, we decide for the patient. We punch two puncture in the radial and radial 6 frame and femoral 7 frame. His shook occlusion in the L6. The first time we go a floppy wire to the L6 and open by balloon with the low pressure, 4 pressure. After that, we see clearly the LED. The problem is the angle of the left main to LED is very high. We curve the wire more curve with the 1 millimeter wire curve in the distal wire. And we use the floppy wire. Very lucky, I can use the floppy wire to the LED. We control from the right to the left and rewire to the membrane. And what technique we choose? Provisional two-stand technique. We choose the two-stand technique. And the technique we choose is the decay crusher. We use the balloon in the middle LED, but the flow competitive from the right to the left is very high. The first stand we use the longest stand, 2.548 millimeter, and we are using the control from the ACA to the places. Open the ostium LED to clearly the LED. After that, we use the second stand in L6 with 2.533. The balloon in LED, left band LED rewind, use the NC balloon in the L6, the ostium L6. And the second, we use the stand 3.533 in the ostium left main to the to LED. Overlap the first stand. Rewind to L6 with the BOT, the left main only with the balloon 40 high pressure. We kissing balloon in the LED and the L6 with the 40 balloon in left main LED and 2.5 balloon NC balloon to left main L6. And now we use the IVUS to see the stand. In the first stand in LED, not good result, but is the proximal LED, not good result. This is the stand 3.5 and proximal and ostium LED. In the ostium, in the left main, I think is the bad result in the left main because I used two big balloon for kissing 40 and 2.75. We decide the both dilatation with the high bigger balloon in the first stand in LED with 2.75 is high pressure and use the 3.5 balloon with 80 atmosphere. After that, we use again the IVUS to see the first stand in LED is the better. And what control the final result of the patient. And the patient now, I have the plan for the patient with check the echography of the treatment, but the epidemic COVID-19, the patient cannot come to the echography again in the treatment. But I can call the patient if the patient is feel good. He can work on okay. After that, maybe next month, the patient can come again with me to check an echo again. Thank you for attention.
Thank Dr. Duy Phương. Now we have about 10 minutes to for discussion about this case, and then we change to the live case because the live case already. I want to listen to Dr. Nguyễn Thượng Nghĩa. Do you think that the way of Dr. Duy Phương, this for the case is the best way? You have some comment about this case, Dr. Nguyễn Thượng Nghĩa?
Yes. Yeah, thank you. Good afternoon, everybody. And very interesting to hear two cases. One case from the 4K, 3K from the Japan, one case from the Heart University, and a very interesting case. In the first case, I would like to ask you, the doctor about the it's very interesting. It's interesting cases for us to learn to share each other. But when you show us the reverse Y technique for the last case, I'm very interested in. But I'm not clearly about that. Can you show us about the reverse Y techniques? I make a curve about 2 or 3 millimeter. It's enough millimeter for the make a curve or not? I'm asking you one question about that. In this case, how to could you can make make a large curve, a large diameter curve in this case or not? I ask you one question about that. The second case from the Heart Institute from Dr. Duy Phương is interesting case for the we share each other. This is left man disease, which protected from the cholesterol from the rise. Very important. In this case, when you do this case, you use the IBP or not? I would like to ask you one question. The first question, because it's when support, because the ejection present in this patient very low. In this case, I think if you have the IBP, it is very useful for the patient. It's safe for the doctor, interventionalist, when we do the procedure. I agree with you. We can do the PCI. The case is very interesting. When you do you wiring, the first why you don't use the iBus to record, iBus to record everything in the left man disease and the ostium, the lesion in ostium left side and the ostium LAD. I think if you have the iBus before we PCI, very useful for us. The second, after you delay with the balloon, NC balloon 2.5, 15 millimeter for open the left man disease and the LAD and left serve. Can you show us the angiogram before you do the strategy for bifurcation lesion? Because usually most of the case in the left man, in this case, is the angle between the left surge and LAD left man always mostly 90 more than 70 degrees. So in this case, in my opinion, I lie to you the provisional T-stand, and if the gel balloon up the left surge, I use the reverse T-stand reverse. It's in my opinion only. In this case, you do the decay crust. The final angiogram very beautiful, and congratulations for this case. Can you review? And And this case, after you do I saw some in the left man. I don't up the fully up position up the stand to the left man wall. Can you? I think you can use the bigger balloon, for example, for 4.5 to open for the final POT for the fully position of the stand. I think in my opinion, yes. You see, yes.
Thank you for Dr. Nguyễn Thành Nghĩa. So the first question to Dr. Soichi Kuramitsu about the technique.
The review. Show us again. Experience in you the reverse Y technique, the lesion of the bifocal lesion with a strict angle, line like this. Because in this slide, all make occur only the 2 or 3 millimeter from the tip of the Y. I think it is not enough.
Okay. So, Mr. please to show us again about the technique you use.
Thank you so much.
Okay. I would like to more interested in the reverse Y techniques. Yes, okay. Because I saw I meet 1K. I see 1K like this. Very difficult. It takes me 3 hours to pass the wire. I'm sorry. Yeah.
Thank you for your question. Yes. So actually, you know, so we sometimes experience the difficult bifurcation region with very sharp angle, so between the main branch and the side branch. So
yes.
So
you make
So
yes,
about regarding the length of the wire. So
yes,
from the second lumen.
Yes.
So can I show you my slide again? So maybe it's an easy way to understand. So how to perform the reverse guided wire technique.
Okay.
So I will share my slide.
Yes, you can share your slide.
Okay. So can you see my slide?
Yes.
Okay.
Yeah. Yeah. Thank you.
So so as you ask me the length of wire chips. So usually, so we set around 3 meters, not 2. Okay.
3 meters.
Yeah, 3 meters. So however, it depends on the lesion characteristics. Okay. So and this is a trade-off. So between the benefit and disadvantage. so when the side branch have a severe stenosis, so it's a very difficult to advance the second wire. So after recrossing. So that's why, so we usually set around 3 millimeters. So however, in some cases, if we set the length is too short, so it's also difficult to advance guide wire to the side branch. So that's why, of course, in some cases, we fail to advance the reverse guide wire. So because, you know, this wire is intentionally fractured.
Okay.
So that's why.
Okay, thank you.
So when this reverse wire little bit advanced, so in some cases, we have to change the guide wire, so using microcasters. So it depends on the situation. So however, in general, so we set around 3 millimeters. So as a length of the guide wire from the second lumen. Okay.
Thank you, Dr. Soichi Kuramitsu. Okay, we know clearly about
yes, okay. Thank you, Dr. Yes.
Dr. Ji Phương, you have a three questions. The first question, why you don't use IIBP for your case? The second question, why don't you use the IVERS before we put the stent, we do the procedure for the left man? So maybe two questions first.
The first question, I have the IBP, but I prepare the IBP, but not use the IBP in the after.
This means that standby.
Yes,
yeah?
standby.
Yes, okay.
The second is the patient have the low pressures. I want to do quickly for safe for the patient. And after that, the stenting, I use the IVERS to check again for the stent. The third question, I use the two times kissing in the left main area and left main CX. The first kissing, I 40 2.5 2.75 balloon with the low pressure in the is the first kissing. But after that is the first kissing. But after that, I use again two balloon, 40 and 2.75 balloon in only left main. Is the first kissing, and the second is the two balloon. This is a two balloon, 40 and 2.75 is the bigger, the 4.5 balloon. I think this is enough for the beauty for the left main and ostium left main.
And so at the angiogram after the balloon. After you open the left main disease. Can you show us the angiogram, the final, especially for the spider view? I would like to see.
Okay, when we wait for the sharing from Dr. Ji Phương, I want to listen to Professor Nguyễn Ngọc Quang. Do you have any comment about the lecture of the Dr. Kuramitsu and the case of Dr. Ji Phương? Please.
Thank you very much for the great talk from Dr. Kuramitsu, and I think that the evaluation, the side-brand occlusion is very crucial for the bifurcation PCI, and it's important to identify the three key factors Dr. Kuramitsu mentioned in his lectures. However, I have one question for Dr. Kuramitsu. Is there any situation the prediction is not correlated with the real scenario? Is there any situation can explain, for example, like you predict that the side brand is not occlusion, but after you putting a stent, the side brand is occlusion. So what is the main reason for the failure case like that? This is a question for Dr. Kuramitsu. For the case of Dr. Ji Phương, and I think that IBP standby is quite a good option, because the patient is likely a stable situation, and if the patient is stable and very good collateral from the right to the left, and you might not need to IBP. Of course, IBP is better option, but somehow if you can do very fast and you open the cert first and you see everything well, and then you can end up with a good result without the hemodynamic support. So I think that his plan is quite good and also save some cost for the patient. Thank you.
Thank you, Professor Nguyễn Ngọc Quang. So, Dr. Kuramitsu, you have one question. May you answer this question?
Thank you for your question. So I'm sorry, so I missed your question. So once again.
Okay, Dr. Kuramitsu. So
yeah.
sometimes you see the IVUS, so the side branch is unlikely to occlusion. But after you put a stent, the side branch is occlusion. So what is the main reason for this kind of case?
So honestly speaking, so I never, I have not frequently so experienced such a case. So actually, so we usually IVUS or OCT, so to predict the risk of side branch occlusion. That's why, so I'm rarely so experience such a case. So in most cases, so we can predict the side branch occlusion. So however, so we cannot completely so predict the risk of side branch occlusion. So however, we avoid the side branch occlusion, but the prediction is not completely correct. So sometimes yes, sometimes no. So however, I think the prediction or preparation is the most important. Okay, so if so, we do the optimally prepare the lesion preparation or appropriate technique. So some case side branch is occluded, but some case is open. Yeah.
Thank you. So in the real life,
IVUS or OCT, we can predict the side branch occlusion or not, but not completely 100% we can predict that. So
yes.
For the safety, we can use protection YE to make sure that it's safe for the patient. So Professor Nguyễn Ngọc Quang, what do you think about it?
Yeah, I think it is great because sometimes when we see the bifurcation and sometimes we think that it is not difficult case and we just go ahead with the stenting and we got a problem with the side branch occlusion and then we regret that we don't use the IVUS from the very beginning. So I think that we should think about the side branch occlusion and use the IVUS as we can. And also one tip very important from the Dr. Kuramitsu is you see on the stent view and you can see more thing about the calcification. And when you see the calcification, I think you should do the IVUS to prepare the lesion. At least you can identify the probability of the side branch occlusion, and also you can choose the way to prepare the lesion. For example, like for the second case, he chose the rotablator, and I think it's a very good option because without the IVUS, you think that you can use a non-compliant balloon to open this, but usually you fail for the case like that. So I think that calcification meaning IVUS, and it is will give you the better result after the PCI. Thank you.
Thank you, Dr. Kong Quang. So the light case already on the table. So we just listen to Professor Nguyễn Văn Tân voice. How about your comment on the case? And after Dr. Tân, we will go to the live case.
Yes. Thank you very much for Chairman. Thank you very much for your lecturer, Dr. Choi Chi. I like your presentation very much. So I like the reverse guide test from your experience. So I think the role of the double lumen catheter and the shape of the triple guide wise and your experience is very important and contributed to your successful case. So I have a question for you, very simple question. If we have IVUS to identify the lesion, especially bifurcation for good trajectory BCI. So and if we based on angiography alone, without IVUS, you can you share your opinion? Some critical in the predict the occlusion side branch. The first question for you, and Dr. Yi Phương, Congratulations for your successful BCI. So I have two questions for you. The first, why you don't use IVUS before stenting to left main to LAD? Very important, because you have the IVUS ready for measure the diameter or the correctness of the lesion. Why you don't use IVUS before stenting? And you have the POT at the pause in the left main stenting after kissing balloon. Can you show and share your opinion about that? Thank you for your answer.
Okay, Dr. Kuramitsu, you have one question, and Dr. Yifeng, you have one question about why do you don't use the IVUS before the procedure?
The question, thank you. The question from of the Dr. Teng, but when we do this patient with the low pressure, when the beginning, I was a little scared the safe of the patient. When I can go to wire to the L6 LAD is very lucky. I use the quickly for the patient for safely, and I don't use this is the reason I don't use the IVUS before the stenting. But I have the question for the Dr. Kuramitsu. The second case of the Kuramitsu, you use the rotablator for the LAD. But I remember the patient have 70 years old, and he's have the very big diagonal, and in the middle diagonal have the stenosis is very high. Why you don't stenting in the diagonal?
Thank you for your question. So actually, before the procedure, so I performed I measured the FFR, so for the diagonal branch. So as a result, FFR is negative. So that's why, so we treated the only main branch lesion. So however, so in that case, so we perform KBI. So because the diagonal branch has the 75% stenosis, as you mentioned. So anyway, so we decided the PCI strategy based on the FFO and the IVUS finding. Okay, this is my opinion.
Thank you, Dr. Kuramitsu. Now we move to the live case. Now, UMC DSA staff, you can start your case now.
Good everybody. Welcome to the live case today. We have I'm Dr. Vũ from UMC, and this is Dr. Vinh from UMC, and this is Mr. Nick from head nurse of the cath lab. So let me introduce the case. Dr. Vinh will introduce the case, please. Good afternoon, everyone. I'm Dr. Vinh from UMC. Today, I would like to share with you the case. This is a 59 years old male. He was admitted to the hospital because he has chest pain for 2 days. The pain is on the left side, lasts for 10 minutes and subsided. He denied softness of breath, fever, coughing, and heart pounding. He was managed at the outpatient clinic without improving his symptoms. The previous history, he has deployed the stent in the LADs in the April 2020, and he was deployed the stent in the circumflex in the August 2021. Next. Next. And cardiovascular risk includes diabetes, hypertension, and he's a smoker. Next. Next. The working diagnosis is low risk unstable angina with grade score 58, and ECG shows the sinus rhythm. ECG shows the Q waves at least from V1 to V3. The echo shows no stable kinesis and left ventricular EF is 68%. And let me show you the coronary angiography. Bấm rồi. Okay. Share. Slideshow. This is angiography in the August 2021. Here is the RDL caudal. We can see the mid dose in the circumflex is visibility of the 80%, and the left man you can see the left man is narrowing about 50%. Next. And in spider view, we can see the middle circumflex is severity of the 90%. With the next, the RCA show is narrowing not significant. With the coronary investigation, we decide to deploy the stent 2.5 40 millimeters in the circumflex, in the middle circumflex, and after that we decide to finish our procedures. And today the patient has the persistent or stable angina with CCS grade 2, and with the coronary angiography before, we think about the lesion is the left main and bifurcation. What is the next best step for management in this situation? And thank you. I finished my case.
Văn ơi, Văn cho cái màn hình đế tay lên đi Văn. Không, cho màn hình đế tay của hình chụp hôm nay này. Tắt mang cái máy tính để nhìn thấy đang nói gì. Tắt cái xe đi. Tắt cái xe. Bây giờ mình tắt cái xe, cái máy tính đi.
So, Dr. Vũ, the angiogram is the past now. You check the angiogram now.
Of course, I do it already. So, can you see the angiogram?
Yes.
So today angiogram, you see in the TB view, we have the left main stenosis, maybe borderline lesion, stent in the LED, 3O, I think it's okay. After the stent LED, we have middle LED, we have borderline lesion, maybe 50% of the mid LED. And the left main also, we see from the ostium to the distal left main, we see the maybe moderate lesion in this case.
So we need to do FFR for the left main or not?
Yeah, I think that is a very good question. So I think that we should have some comment from the panelists about this case. Should we do the FFR for this case, or we do the IVOS, or we directly do the stent for this case?
So I want to know, listen to the Dr. Hoàng Văn. Do you think that we need to do FFR for the left main?
Yeah, thank you, Professor Bing. I think as a more or less that means this case, I think so that only 99 years. I think this case we should to do the FFR. This case after FFR, we need the depends on the result. We decide to do PCI or not. So this case we need to do FFR. Yes.
Thank you. How about Dr. Kuramitsu? Do you think that we need to do the FFR for the left main lesion here?
Yes. So if I'm operator, so I will check the ischemia. So by using the FFR, and however, Dr. Boo, you already checked the IVUS?
Yeah, of course. Yeah, you got me on the screen. I checked the IVUS already, and
okay.
I will show the IVUS for all of you, and to see where if we need the FFR or not after the IVUS result for the circ and the LED. Okay. Okay.
Okay.
Please show the IVUS, please.
So the assessment of left main is a little bit difficult. So FFR is not perfect. Okay, so in some cases, IVUS is very useful to assess the functional significance of left main disease. So that's why. So I'm very interested in the MLA of left main disease. Okay, so could you show us the minimum lumen area of left main disease?
Thank you, Dr. Kuramitsu. How about Professor Nguyễn Ngọc Quang? Do you think that in this case, maybe the IVUS may be better FFR for the indication for the PCI for the left main? Professor Nguyễn Ngọc Quang?
Thank you, Professor Ding, for the very challenging question. And I'm sure that we need some method to evaluate the ischemic. However, to do the FFR in the left main is not easy, and sometimes there is some bias, including when you do the measuring the FFR. So I think that in this case, IVUS can do the both. One, they can give us the assessment of the severity of the stenosis, and if the severity of the stenosis of left main is high, and I'm sure I go ahead with the stenting without the FFR. And also the IVUS can show us and how to choose the strategy for the left main PCI. So I think that in this case, I will believe much on the IVUS imaging rather than the FFR.
Thank you. I agree with you. So, Dr. Vũ, you can show the results of IVUS before the procedure.
Okay, let me show you the IVUS finding. In this case, just beginning, please. This is not beginning. Okay, this is the IVUS pullback from the LED to left main. We see the distal, I mean the middle of LED, we have some lesion over there, just after the stent in LED, and this is the stent. I think the stent is quite good. So this is the proximal. Just a moment, please. Yeah, we see some. Yeah, we see the IVUS. The Y from the circumflex. Stop here, please. Okay. Yeah, you see the IVUS from the circumflex at 7, 8, or 8 o'clock, and we see that in the this is bifurcation. We don't have any classification opposite the osculum. Next, I shall play. Okay, I see this is the left main. Okay, this is the IVUS from left main to LED, and the second from the circumflex to the left main. Okay. Yes. Just negative remodeling a little bit in the proximal surge. And this is the OM. This is the, yeah, this osseum. Please measure the osseum surge and the distal labment, please. Khoan measure, bật cái hình đo đi. Đo labment bao nhiêu? So what do you think about the IVUS? Dr. Soichi, is it enough for PCI or we need to do the FFR?
Thank you, Dr. Boo. So, why it's the MAA? So 4.0?
Yeah, this is the first. This is the labment distal from the.
Oh, okay.
And
so
just back a little bit.
Honestly, so I little bit difficult to listen to your voice. So, however, anyway, so according to this IVUS image, so I think that this region is significant. Okay, so because the MAA of left main is 4.0, so you know the cutoff point of left main is 4.5. Okay, so that's why this region is significant. So based on the IVUS finding. So according to the current experts document, so when the IVUS shows the MAA is 4.5 to 6.0, so we should measure FFR to assess the functional significance. So however, when the MAA is over 6.0, we can defer the revascularization. So based on the IVUS finding. So in this case, so once again, the MAA is 4.0. So that's why the region is significant based on the IVUS finding.
Thank you, Dr. Kuramitsu. I agree with you. So just 4.0, so it's a significant stenosis of the left man. So we can do PCI for the left man now. Dr. Wu, may you continue to the procedure?
Yes. Please show me because we measure the distal labment by two pullback. The first one from LD, the circumflex from the second one from circumflex to make sure that the measurement is okay, is correct. So this is the 4.0 from circumflex pullback. So how about the LED pullback, please? Show the labment distal diameter and MOA. Không, cái view mà anh đã đo lúc nãy á, em đã đo lúc nãy với anh rồi. Không, đó đo rồi, đó bao nhiêu? Cái này là labment LED. LED đâu? So can you see the picture of IVUS?
Yes.
Yeah, so this is the pullback from the LED. Also, we see the MOA is only 4.0. So I think the measurement for IVUS from the both brand LED and circumflex, I think it's the same diameter and same LA. So I think it is correct measurement. So because of it's under 4.5, so I think we in daily practice we don't need any FFR. Of course, if we want to do something more, we can do the FFR for the lemma. I think it's okay. So this is the IVUS finding. We think that the first one, the IVUS, show us is it the significant lesion in the labment or not. So in this case, we have significant lesion. So the second question is about the strategy for this case. So what do you think about the strategy for this case? Only 1 cent provisional or 2 cent upfront for this case? And how about what kind of technique of 2 cent in this case? Please give us some comment for us before we do the procedure. Thank you.
Yes, thank you, Dr. Wu. So, Dr. Trần Hoa, do you think about the strategy for this case? You can choose the what technique and 1 stand or 2 stand, etc.
I think in this case, very interesting case. In this case, I think with IVUS, in this case, I choose one stand technique for only one stand for left man and left man LID one stand, and but I can choose one stand and provisional for LCs, and I can check after stand and IVERS and angio, and after that we can choose stand or not for LCs.
Thank you, Dr. Trần Hòa. It means that you just use the stand from LAD crossover to the left man, and then you can see what happened after that. And
I would like to ask one question, Dr. Bình.
Yes.
Dr. Vũ. Yes. Dr. Vũ, can you show us the IVERS of the ostium of the LAD and ostium of the left sub before you decide the strategy for the patient in this patient?
Okay, Dr. Nghĩa, I will show you the MOA of the third ostium and MOA of the LAD ostium. So
yeah.
So you see the
left sub.
Yeah. This is the LAD.
Ostium left sub. LAD left sub.
This is LAD.
LAD. Yes. Okay. Very good.
It's a 4.5 mm square.
Yeah.
And how about third? Please show us the third ostium measurement.
Yeah.
The third ostium. Please show cho em coi cái third ostium.
The ostium of the
ostium of LAD, no, a little bit small, very small atheroma. No plaque. No plaque in the.
Okay. So this is the
small plaque in the LAD only.
Awesome. Không, cái view này không rõ đâu. Ngược lại chút xíu đi, ngược chút xíu nữa. Xíu cho nó bờ nó rõ chút. Cái chỗ vừa đo. Okay. About 3.8 mm square. Yeah.
Yeah.
The ostium about 4.5 mm square and the third ostium about 3.8 mm square. So what do you think?
Yes. Okay. Thank you. It's the minimal lumen area about 3.8 millimeter in the ostium and left LAD. Ostium of LAD. Yeah. How about the surf?
This is a surf. 3.8 is a surf ostium.
Yeah. Okay.
LD about 4.5.
I agree with the strategy from you.
And,
one stand. Provisional stand.
Professor Tân, Nguyễn Văn Tân, how about your opinion about the strategy for this patient? One stand or two stand? What technique you can use?
Yes. Thank you for sharing your experience very much. So in this situation, based on the analysis from the Dr. Vũ, I think we should choose two stand technique in this situation. And Dr. Vũ can do with the K crush technique. I think so in this situation. Yes.
Thank you. How about Professor Nguyễn Ngọc Quang? Do you think that we can choose to stand strategy with the DK crush technique?
No, I think in this case, provisional stand is quite good option. And even the proximal third a little bit small, but I think that after standing from the LAD to the left main, everything should be fine. And I would just prepare the second option for DK crush, but I think the probability for that is low. Thank you.
Thank you. Now I want to hear the comment of Dr. Kuramitsu about the strategy, one or two stand.
Thank you. So I think one stand is enough in this patient. Yeah. So anyway, so could you show us I was provoked from LAD. So I want to see the movie.
Anh Khoa cho coi cái LED play LED box. Các vào trong cái stand, Nữa đi đến gần cái stand. Okay, play here, play from here.
Okay. So as I already deliver a lecture today, so we should always consider three components, okay? So this is a circumflex, okay? So little bit back. Okay, so how about angle between the main branch and the side branch?
Yeah, the angle between the main branch and side branch, we can merge it. Yeah, inverse.
I will show you the angle of the circumflex by the inverse finding. Okay, please show the inverse finding with the angle. Không phải đâu.
Yes, yeah, actually, okay. You know, as you know, the longitudinal view is so important to assess the angle between the main branch and the side branch.
Yes, I agree with you. We just use longitudinal to see the angle between the main and the side branch.
Okay. Okay. According to the IVAS finding, so the angle is not so sharp. And also looking at the IVAS pullback from circumflex. So as already mentioned, so there is not so much plaque as the ostium of circumflex. And also, how about the plaque volume and the plaque characteristics at the opposite side of side branch? Could you show us the IVAS image at the bifurcation?
So, Dr. Vũ, how about the characteristics of the plaque opposite to the side branch?
Okay, I will show you the plaque. Okay, this is the LED pullback. You see the circ ostium and the Y from the 9 o'clock? Yeah.
Yes.
Yeah, you see that? Okay, so in this view, we see maybe the circ ostium is not so severe. And at this bifurcation, we see the plaque from 4 o'clock to 9 o'clock. We have maybe the mixed plaque in this size. And opposite to the circ ostium, we don't have any lesion.
Okay.
So,
okay.
I think that the cardinal shift in this case is not so high risk. So I think it's a very low risk of cardinal shift. And please back a little bit, please. Yeah, you see that the plaque also from the 4 o'clock to 8 o'clock, not too much from the opposite side of the circumflex ostium. So what do you think?
Agree, Dr. Vu. However, and also, could you tell us the proximal region? So the left main region. So could you show us the proximal difference of the region?
This is the circ ostium.
Yeah.
Tới khoan. Ngược lại chút xíu. Yeah, you see.
So you know, in clinical practice, when treating the left main region, so there are often discrepancy between the proximal and distal difference. Okay, so especially when treating the left main region. So that's why, so you know, we should always consider stent over expansion capacity. Okay, so that's why, so you should check the proximal and distal difference diameter. This is a key point. So to choose the optimal stent type.
Dr. Soichi, what do you think about the circ ostium? Because if we try to do the second stent, I mean the 2 center front, the circ ostium like this, maybe it's easy to get the plaque shift from the stent ostium to the LED. So what do you think about this? 2 stent or 1 stent technique?
So answer is simple. So 1 stent is enough for this patient. So okay. However, so as already mentioned, the no component are met. So in this patient, that's why. the risk of side branch occlusion is low. Okay, and the
yes. So keep it short and simple. I want to know the opinion of Dr. Hoàng Văn. What do you think about this case? You choose a 1 or 2 stent trajectory for this case?
Yes, I think in this case, one stent is I think okay because osteum of the circumflex is the plaque is it's moderate, and the volume of plaque in that means is maybe it's not flaccid after stent, not much flaccid after stent, that main and LED. So I think one stent is okay.
Okay, thank you. So Dr. Vũ, you can continue the procedure now.
Yeah, thank you. In this case, I think about the two-stent technique. I DK cross, similar to Professor Tân told me that. But in the iverse, we see in this picture, the third ostium, we have the opposite side of the LED ostium. We have some plaque, mixed plaque over there. So maybe if we put the two-stent technique, maybe we have suboptimal result for the ostium of either third or LED. So I wonder 1 or 2 stent, but at the beginning, I think about 2-stent technique, DK cross. So, okay, I will try to DK cross in this case. And how about the chairman, the moderator? What do you think? If you would like me to do the DK cross or just 1-stent provisional for this case?
So majority of the panelists agree to do the 1-stent technique, but depend to your experience. If you have many experience about the DK cross, you can do it now.
Yeah. So I have one more question before I start to do the procedure. We have the EBC man trial about the provisional stent. What do you think about EBC man trial? We can apply this trial in this case or not? I would like get some comment from the panelists.
Okay, very interesting question. How about the answer? Professor Nguyễn Ngọc Quang, do you know now just we have one article published maybe 3 months ago about the EBC man trial. What do you think this trial? How can we make we apply this result to this case? Okay, Professor Nguyễn Ngọc Quang.
Yeah, I just sorry, Professor Bing. I just checked again the criteria and criteria to inclusion the patient. I think that it's up to you, but normally for the life care like that, we don't suppose to get the patient in the trial, I think.
Okay. So in that trial, they said that we can choose a provisional stent. It may be equal or better than 2-stent technique. What do you think, Dr. Kuramisu, about the EBC man trial?
Thank you, Professor Ben. So as you mentioned, so EBC trial demonstrate the provisional stent strategy. It's good option. So compared with the 2-stent strategy. So actually the result is a little bit different from China trial, so DK crash trial. So however, so I think this case is not true bifurcation. So according to the angiogram and the iverse finding. So that's why I think provisional stent, so I mean the 1-stent strategy is good enough for this patient. This is my opinion.
Thank you. So Dr. Soichi said that the 1-stent is enough. I think that trial say that if you don't have enough experience and the devices for the procedure, we can choose provisional chest stance technique is better. But if you have enough equipment, for example, IVers, and you do more than 300 tests a year with 15 lap man per year, so you can use decay crust technique. It may be better than a provisional technique. What do you think about that, Professor Nguyễn Văn Tân?
Yes, I agree with your comments very much. So up to now, Dr. Wu have IVers, so very clearly the reason. So in this situation, depend on the procedure and depend on the Dr. Wu. If we have any experience in this situation, we have 2 decay crust statistics and another one, you can say the provisional statistics. And then after stenting from the left mental LAD, so we evaluate on the ortho LCs, and we can stent in modified technique or something like that. I think so.
I have a question with this case where your plan, we can direct stenting in this case or not, or you choose prepare with balloon. I think we can direct stenting for left main LAD, no?
I think if you direct stenting in the left main LAD, I think it's okay because we have the characteristic of lesion in IVOS. We have no have we can see fire something like that. You can direct stenting. I think so enough. In this case, but Dr. Wu maybe do with the decay crust technique in this situation.
Yeah.
So maybe the young doctor will do decay crust, but to me, I'm over already. So I just pay attention about the time between the door of the cath lab to the door of my home. So we do it short and simple, and come back home with my wife. Is okay?
So because I think in this case, if we do the provisional stent, one stent only for left main LAD, we know that in the BCMN trial, only we have the 20% patient, 22%. We have to crossover. I mean that we have to change the strategy from the 1 technique to the 2 stent technique. So I prefer the decay crust in this patient at the beginning. So what do you think about the balloon in the decay crust from the LAD to crust the stent from the circumflex? We choose the balloon size. Is it according to the LAD diameter, or we choose a balloon size according to the left main diameter?
That question maybe is said to Professor Nguyễn Văn Tân. Do you may you answer the question of Dr. Wu now? What size of balloon you can use in this case for the LAD, for the circumflex, etc.?
Yes. Thank you for your question from Dr. Wu. Usually we have the IVers measure. So we choose the balloon, the left main to LAD by the LAD diameter for crust. So depend on the diameter of the proximal LAD, you can choose the balloon. Yes. I don't remember exactly in the first time you measure diameter in proximal LAD. What size of the diameter in proximal LAD? Maybe 3.0 or 3.5 or something.
So the diameter of the LD proximal is about 3.2 mm. So
okay.
How about the balloon? I think
maybe 3.0 is enough. Yes.
3.0.
Yeah, maybe, yes.
So what do you think about the diameter of the balloon for cross? Crossing in DK cross. So Professor Quang, you have a lot of experience about the DK cross, right? Please, please.
Frankly, I have to say that I prefer the Q-load. DK cross is not my favorite, but however, we can combine the both technique together. Because the most important thing is how to optimize the oscium of the third after you put in the stand. So I think it is the main thing for the decay crush and also for the other technique if you really want to have the optimal result. Yeah.
So this is the stand in
this is the first stand for the circumflex.
Yeah.
Yeah, this is the first stand. So we have some overlap between the first stand and the second stand. Why you do this?
Yeah, this is the first stand, and remove a little bit.
16, 18. Okay.
So in this case, we had the first stand of the circumflex in the past. And after the stand, we have some black shift from the stand to the proximal of circumflex. Now Dr. Wu put another stand, the second stand of the circumflex from the left man to the mid. The circumflex overlap a little bit with the first stand in the past.
So now I do the cross for the cross stand from the LED to circumflex. Then this is a balloon. Balloon.
Seven, guiding 7 friend or 6 friend. Dr. Wu.
18. This is 7 friend guiding catheter.
7 friend. Yes. Okay. Thank you.
Also. This is the balloon, trio balloon emerged from Boston. We go up to 20, please.
18, 20.
We cannot see the picture from Dr. Wu.
Huh?
We cannot see the picture. Yeah. Okay.
Okay. Again, 20. So the most important key point in the DK cross that after we use a balloon to cross the circumflex stand, we must make sure that this is the complete cross. So Dr. Kuramitsu, can you some experience about how to do the complete cross for the DK cross technique?
Thank you, Dr. Wu. So actually, DK crush is not favorite technique. So, however, the merit of DK crush technique it's easily to keep side branch open. Okay, so this is a big advantage of DK crush. So
this is the I was finding after the circumflex stand and we use a balloon, a trio balloon to cross circumflex stand to the left man. So can you tell us about the cross? Is it complete or not? Please tell me about that.
So Dr. Bud, this IVUS is so after recrossing guide wire into the circumflex, is right?
So this is the wire from LED.
This is the
LED.
The IVUS from LED. Yeah.
So yeah, this is the bifurcation. You see the cross position. Dừng lại anh Khoa. Dừng lại. Yeah, vừa thôi. Okay, this is the cross. Two layer of stand.
Two layer of stand in the left hand. Yeah, okay.
Yeah,
I can see it.
Is it complete or not? So should we do the balloon, the bigger balloon, or just trio balloon? Is enough for DK cross?
I think it's okay. It's enough. So, however, I want to see the angiogram. So I have never seen the any angiogram So after some procedure, so could you show us the angiogram?
Okay.
Okay.
So what do you think? Should we do the bigger balloon to make the complete cross? I think the cross is not so good in this position because the lumen of the left man, I think at the 3 o'clock to the 9 o'clock is a cross position. I think we should make a bigger balloon to make a pot for the left man to make the cross is more complete than this picture. So
yes,
after that,
yes, yes, I agree with you. Maybe you do a bigger balloon to cross completely the stand.
10-15 được set NC. Because the key point in the DK cross is that we have to make sure that the circumflex stand is crossed by the balloon enough. Because if the not complete cross, a lot of difficulties when we require balloon and kissing balloon in the DK cross. So this is, I think, the key point of the cross or DK cross technique for the patient.
What kind of balloon do you use for cross for the stand of the LCS now?
I prefer for the semi-compliant balloon, because semi-compliant balloon we can make a cross from the LD to the left man is okay, but the NC balloon only one side from the proximal to the distal of the balloon. Okay, test please.
Professor
3.5 balloon, please open, please.
Professor Nguyễn Văn Tăng, maybe at the beginning of the cross, we can use a bigger balloon to save a balloon now. If the beginning we just use the 3.0 balloon, now we upgrade to 3.5. Maybe we save one balloon if at the beginning we use a 3.5 balloon.
Okay.
Yes.
So I just make the support for the, I hope that after this balloon dilatation, the cross position in the circumflex stand to the left man may be better. I would like to prepare the lesion before we do kissing for the DK cross technique. So first important in the with the DK cross or other technique, because we have to make sure that everything we do is perfect for the patient and for the lesion. Okay, I will do the. Can you see the IVUS?
Yes. Yes.
Okay, stop. Okay, I do the manual. The manual. Okay, can you see the IVUS now?
Let's see.
Yeah, we see clearly, Dr. Wu. Yeah, you can do.
Okay, this is the LD ostium, and we come back. So what do you think, Dr. Kuramisu? Is it enough cross? We should.
I think it's enough. So please move on to the next step.
So this the step that we have to do the rewind for the stroke. So which why you prefer to do rewind for the side branch after the one stand in the side branch. Can you tell me about your experience about the Y selection in the case like this?
So what kind of Y you use for the rewind for the LCS and
okay. Cái bóng này trong phòng.
And I know Professor Hồ Tường Dũng and Professor Nguyễn Văn Tấn very interested in the decay crust technique. What do you think about this case? Now we need to rewind for the circumflex now. What kind of Y you can use in this case, and where the proximal or distal of the circumflex you can use the place for rewind.
Yes, thank you for your suggestion. Usually we use active soft Y, for example, Rendezvous Y, Zone Y, BMW Y. If we successful pre-cross Y to the circumflex, we can continue to do the procedure. So sometimes very difficult. You can abstract the hard Y, for example, hydrophilic Y, something. So very, very important if you rewind in the circumflex. In this situation, we should find out in the proximal. Very important in the decay cross techniques. If we successful rewind and continue to step up the decay cross technique, very simple. So, yes.
Thank you for the T and propulsion or T technique. We can use the distal rewind. But for the decay crust, we use a proximal rewind. So for the circumflex.
Bóng bao nhiêu? Cái bóng 2.5 nó được kissing.
And now you are kissing.
Yeah, the first kissing for decay crust.
What's the upper load in the circumflex? Is it in this case, Dr. Yu use it? What's the upper load in the circumflex? For the first case,
about 2.0 for balloon, and after that NC 2.5 balloon negative. Maybe we have some difficulty. Okay, maybe we need a big new balloon.
Maybe we need newer balloon or just smaller balloon.
Cái 30 không. Cái này là 2.5. Lấy 2.5 bóng thường. So So Dr. Quang, Professor Quang, how about the first kissing? We use the is it what you prefer?
Sorry, I didn't hear you quite well. Can you repeat your question?
For the first kissing, first high balloon you prefer the Nancy balloon?
I didn't hear quite well, but I think that you're asking about the balloon for the first kissing in the for the decay crust, and I think that if I can go easily, the first one I go with the 2.5 normal balloon first, and after that I go with the 3.0 or 3.5 non-compliant balloon. Because the standing in the cert, I think it's something like a 3.0, right? So the first kissing, we can end up with the 3.0 NC balloon for the cert. But it depends how you go easily into the cert or not.
Yeah. Okay, yeah. So we can use the balloon of previous.
Rồi lên. Lên. So the first kissing now. 6. The position of the two balloons is not so good. What do you think? Can you change the balloon position for the kissing? The better kissing balloon. Do you have any tip and trick for this?
Oh, no, I think now you can go. You can put a bigger balloon in the cert. So I think the 3O at this point, non-compliant balloon should be fine. Because the on the image, I think that the balloon a little bit small compared to the vessel size.
So you prefer the NC balloon 2.75?
Not at this point. I think for me, I don't know about the experience from Dr. Kuramisu, but for me, go slowly, step by step, to prevent deformity of the stand is more important for the any kind to stand technique. So I don't want to jump up very fast of the balloon size. Slowly, but maybe costly for the patient. But if you want to have a good long-term result, and I slowly increasing the size of the balloon. Yeah.
Bao nhiêu 30 nhiêu? 24. So is Dr. Quang talk about the left main stand deformation in the left main PCI. Yeah, I think that's the important point when we do the left main bifurcation. When we put a stand from the ostium of the left main. In the
no. I think in this case we're discussing about the kissing balloons, and for the long-term result, everything is depend on how the restenocyte crest of the side branch. So that's why you need to optimal the stenting for the L6 ostium. So that's why I don't want to jump very quick for the balloon for kissing. Slowly, but because I don't want to increase too much of the size of the stand and then deform the stand. What do you think about that, Dr. Kuramisu?
Thank you. Yes, I agree with you. So, however, in my clinical practice, so I decide the balloon size for KBI according to the IVAS image. So, however, so when we choose the two-stent strategy, so it's a little bit difficult to obtain the optimal result. So in most cases, the stent deform occurs. That's why, so maybe, so I'm not sure, but so to get the optimal two stenting, so OCT guided PCI is maybe better. So because, OCT make a 3D image, so we can easily understand the location of stent strut. So of course, there is little evidence to showing the benefit of OCT guided PCI. So anyway, yeah, this is my opinion.
Yes, I agree with Dr. Georgie. To evaluate exactly the diameter of the proximal AVD or circumless or left main OCT, very important and very exactly. So in our CAT labs, we have usually we use OCT to evaluate the diameter from the proximal circumlateral AVD before stenting the left main.
So this is the aerial view for the left main ostium stenting. So what do you think about the position of the stent now, please? Is it good? We need to go further.
Dr. Wu, what's the stent? What's the stent of left main AVD?
This is trio synergy, trio.
Trio?
Yeah, trio. Trio can upside to 4.25.
Oh, yeah. We can remove y from L6. We fix y
Okay,
of
we remove the y from circumflex. Okay, Dr. Hoa asked me about that. Okay, okay.
So
why don't you use a big stand just to treatment?
I think 3.5 is in this case is okay.
So how about the position of the stand? Is it good for the ostium left man, or we go for the take a picture, please?
So Dr. Bu, so this is Shoichi speaking. So I think, so, you know, it is difficult to identify the left main ostium. So from this view, so I think the IBUS marking, so it's so important to identify the left main ostium. So did you perform the IBUS marking of ostium of left main?
Okay. You mean that we use the IBUS and the stand at the same time, or we just marking the IBUS first, and after that we move the IBUS and we mark at the point and we use a stand? Yeah.
So you know, so this that is my style. So Kokura style, Japanese style. So to check I always perform the IBUS marking. So to put the stent as the ostium of left or right coronary artery.
Yes,
okay, I will do IBUS, and please show me the IBUS marking in this case for the left main ostium.
And also, you know, the angle, the angiographical view is also important to identify the ostium of left coronary artery. So maybe this is the ileocranial.
IBUS, please.
So I think the LAO is a default viewpoint. Yeah, IBUS.
The manual đi anh ơi. Manual chưa để anh có tay cho nó dễ. Okay, Dr. Kuramitsu, where is the ostium? We have some dissection here.
There is not yet ostium, so little bit back.
Okay.
Oh yeah, here.
Okay, right here. Take a picture, please. Yeah. Is it okay in the picture? You see the picture?
Yes. So, however, I already pointed out the angiographical view is not so good to identify the ostium of left main coronary artery. So, please check the LAO. So, simple LAO view.
This is the LAO view. Can you see the LAO view?
This is a ileocranial.
Cranial, yeah.
So
can you see that?
Yes, so please change to the LAO view.
This is LAO view. You mean IO or LAO?
Not. So this is ileocranial. So
yeah, ileocranial.
So I think the LAO 40 degree is a default view to identify the ostium of left main coronary artery.
Just LAO 40 degree.
Oh, okay. This is LAO. So please check the angiogram.
Again?
Yeah. So before checking IBUS, so could you show us the angiogram? So if we can see clearly see the ostium of left main, this is a good view to identify the ostium.
You see the
yeah, this view
dissection
is
of the
better. Yeah, to identify the
we should
ostium.
put a stand right now because we have the big dissection in the left main.
Yeah.
Worry about the IVUS. Make it stand.
So
maybe we take time for the IVUS. Maybe the left main total occluded.
Okay. However, anyway, this angiographical view is better to identify the ostium of left main.
Yes, now the ostium of the left main very clearly now, so we don't need to use the IVUS to make a mark for the stand.
Okay, test please. Is it good? Dr. Kuramisu, more this is take a picture. Okay.
The movie does not work very well, but maybe okay. I'm sorry.
Want to push more or pull back?
So anyway, so as you mentioned, the dissection already occurs. So please put the stent.
Okay.
Yeah.
Okay.
So I think it seems okay. Little bit protruded to the ostium outer, but it's okay. So because the plaque continue from the ostium of left main.
I think we can advance a little bit. Yeah. So
Dr. Hoa want to advance more?
Yeah. But it's okay now.
Yeah, I think advance more is a good option because if you do redo PCI, if the stent protrude too much to the left main, to the aorta, maybe we have some difficult to engage the guiding, also the balloon. Okay, open again. No. Okay. Okay, so now what we do next? We need to pause or rewiring and do kissing. Dr. Quang, what do you think?
No, I think in this case you must put first because the small size, because the stand in left hand a little bit small. And also to fix the dissect of the left main, so you need to POT first to make sure that the stand is cover everything.
Yeah. How about the size of the balloon for the?
Yeah, I think for me every left main should be 4 at least. So
for balloon, Dr. Quang suggest for balloon, please. For 10.
Why don't you do IVUS now?
I think the stand is not fully expansion. So if we do something for that one, it might cause a problem with the stand. So you need to make sure that stand is fully expanded first. So anyway, you should do the POT. So just POT and prepare for the other thing. If you got a good POT, and then you can do everything you want, I think.
Yes.
Is it a good position for pot, Dr. Quang?
Yeah, so good.
Okay, I'll open. We up to 18. Okay, down, please. Okay, again. 20. Dr. Kuramisu, you have some case that the stand in the ostium is prolonged. I mean that it's longer than at the beginning because we have the high pressure balloon. So in this case, you worry about this or not? The stand in the left main?
So it depends on the location of stent. So actually, if stent, it's maybe in this situation, stent is malopose. So because the little bit smaller, so compared with the vessel diameter. But so that's why So I will check the IVUS so before the port. So in my clinical practice. And so we choose the optimal balloon size. Anyway, please show us the IVUS image.
So, Dr. Nguyễn Ngọc Quang said that we do port before we do IVUS again, and Dr. Kuramisu said that maybe we can do the IVUS first and then port later. But I think that it depends on the situation. I think this situation, in this situation, I think I will do both before we do IVUS for the safe for the patient.
So now we rewind to the cell complex before we do IVUS and kissing. In our cath lab, we prefer to use a double lumen catheter because in this kind of case, we have the stent protrude into the aorta. If we don't use a double lumen catheter, sometimes the why for the circumflex, we rewind in outside the stent. So we prefer the double lumen catheter in this case. It's in the left bifurcation with the two stent technique.
Yes, if you have enough the catheter and enough money for the procedure.
Yeah.
Yeah. So this is crochet micro catheter, double lumen catheter. You see the marker of the crochet, and we try to rewire. Yes. Yes. Rewire. Stop, please. Give me the balloon to. Kuramisu, now I will check the IVUS, and can you show me the how to detect the circumflex while going to the distal shot proximal shots by the IVUS finding? We will do the IVUS for this case before we do kissing, because we know that the decay cross, the optimal Y position is in the proximal of the shot in the circumflex stent. So I will check the IVUS and please show us the. Okay, take IVUS. Normally for the decay cross, the procedure will take time about 90 minutes. So maybe this case we take over 90 minutes. LED, IVUS LED to check the Y for the shot. Is it in the proximal shot or distal shot? Okay, LED pull back, please. Oh, cái này bị nhảy lên. Tập trung vô nè. Làm lại anh Khoai. Stop. Ok rồi, tôi bắt đây. Yeah, this is the left man. Yeah, you see the very big left man here. Yeah. Yeah, the stent protrude about 1 mm to the aorta. So can you show me the Y in the circumflex by the longitudinal view? Kuramisu, can you see the IVUS?
I can see the IVUS, but the movie is not so good. That's why it will be difficult to identify the decrossing guide wire. So
the Y in the proximal or in the distal shot? We prefer the proximal, right? In the decay cross, it should be in the proximal.
So maybe, so the second wire is coming from the 8 o'clock now. So, so at least the recrossing point is not distal. So according to the Albers finding.
Không, cái mũi tên thôi.
So however, so honestly speaking, so it's difficult to identify the second wire.
Kéo cái thanh nó ra ngoài á, để đó nhìn không thấy đâu. Rồi, lỗ xuất phát nằm ở đâu? Chiếu cho mọi người coi nè. Đó, rồi. So where the wire? Can you see the wire? Okay. Cái bóng 2.0
So could you show us the IBUS image at the bifurcation region and or at the ostium of
Thôi nãy
circumference?
anh nói nhớ lúc gọi thương rồi không bao giờ bắt máy hết. Trời ơi, giờ em mới gọi lại sao được. Lúc cắn rồi thôi giờ rồi.
Sắp hết giờ rồi kìa.
We cannot see the guy why.
Can you see the guy why? Yeah.
So Dr. Boo, so could you show us the IBUS image at the ostium of circumflex?
Yeah, okay. Chỉnh cái chỗ.
So I think this is not ostium. At the ostium of circumflex.
The angiogram. Văn chiếu cái hình ảnh chụp mạch vành cho mọi người nhìn cái hình đó.
Okay, so this is a second wire.
The short ostium, and you see the wire. Yeah. Where the wire?
If possible, please zoom up the IBUS image. So, however, so I think so the wire position is not distal. So
yeah, I think
it seems proximal.
At the proximal, so we cannot see it here. Chỉnh cái view phía trên kia để nhìn cái quai từ thân trung đi xuống. Không chỉnh đúng rồi, em kéo từ thân trung thì thân trung đâu quai circumflex đâu.
Proximal or middle.
Đâu quai circumflex đâu.
So now we can see the second wire. So stop. No. So stop. So now the second wire, we can see the second wire at the 9 o'clock.
Yeah.
And also we can see the this one.
Yeah, I think the wire in the proximal short of the circumflex in this image, IBUS imaging.
It looks like proximal, huh?
Yeah, I can tell that similar to Dr. Kuramisu is not a distal, but I'm not sure about the middle or proximal, frankly.
So the second case maybe it's quite difficult. Chọn thêm cái bóng mới. 1.5 cũng được. Now we use a tour balloon, reduce, but the tour balloon cannot cross the ostium. So now we use a new one to open the third ostium because we have a lot of layer of sand here. Okay. Wow, quite difficult. I think we need to do 4 more. Okay. Open, please. Open. 12. This is 1.5 balloon.
12.
Okay. Okay. Okay, 12 again.
12.
Maximum is 12 or 14.
14.
Okay, down. Okay, now we the guiding is not quite so. Nằm nghiên chú ơi, không sao vậy chú? Kéo xuống rồi. Okay. Yeah. Rồi, ở trên cái bóng 2.0. A lot of maybe we need a new balloon because 2.5 new balloon to open the shot.
Chú ơi, chú nằm yên giùm chút xíu.
Cái tay đau hả chú hả? Cái tay á hả? Tại vì dùng cái ống thông nó hơi lớn đó chú. Tay nó hơi đau một chút. This is two balloon. Okay. This is a reduced. Open please. 16. Okay, down. Okay, now we use a bigger balloon. NC balloon, please. 2.75. Anh Khoai đo dùm em LD short black custom 2.75 không? Cho cái bóng mới 275 chưa có cái mới. Hoàng ơi. Okay, now we use an NC balloon to open the shot from the circumflex. 275 NC. 275. 275. Okay. So, Dr. Kuramisu, how about the kissing balloon, final kissing balloon? You prefer the NC balloon for the both branch or just one NC balloon and one semi-compliant, and how pressure would you go to?
I usually choose the non-compliant balloon for KBI.
Okay. So I just do balloon for the overlap stand, and now for the circumflex ostium. Okay. 20.
20.
Okay, 20 atmosphere. Okay, down. So how about the balloon for the LED? We should choose a 3 or 3.5 NC balloon.
I think 3.5 might be better for long-term reason.
Đây cái 3.5. Oh yeah, oh, I'm sorry. I just removed the balloon from the circle, so it's not easy to go again. Oh, I'm sorry. Lấy lại cái bóng NC mới.
2.5 cho cái bóng NC 2.5 mới.
Lấy cái bóng 3.5 chứ. So in the DK cross, we have to spend a lot of balloon.
Một cái 2.5 mới.
Okay, the balloon for LED. Lên nhà lên. Lên để nâu cái overlap. Lên đi lên. 12. Rồi được rồi.
Yes, Dr. Choi Chi, you can leave the webinar at 6:30. Yeah. Thank you very much.
Dr. Vu,
Yes.
can you hear me?
Yeah, I can hear you.
Okay. Okay. So unfortunately, I will have to leave the webinar. So at the 5 minutes later.
Yeah.
So I'm apologize for my duty or my schedule. So anyway, so I hope you will get great success in this case. And once again, I appreciate all of you and all panelists for giving me the great opportunity to join this great webinar. So I hope to keep in touch with each other. Thank you so much.
Yeah, thank you, Soichi, for helping us to have the robust. Xuống. Dạ, rồi lên. Yeah. Rồi lên. Okay, thank you very much. See you later.
Thank you very much. See you
Thank
again.
you. See you again. See you soon.
Yeah.
Thank you, Dr. Karumisu, and see you again.
Yeah, see you. See you soon.
Yeah, thank you, everybody.
So.
And leave because cảm ơn anh Bình, cảm ơn tất cả mọi người rất là nhiều.
Ok, anh chào Nghĩa.
Okay, dạ chào anh. Dạ. Cảm ơn mọi người. Dạ rồi.
Thôi xin quay cảm ơn bác sĩ Tân.
Chương trình mọi người còn rất là nhiều câu hỏi thảo luận của các bác sĩ, các bạn đồng nghiệp ở nhiều nơi gửi tới. Thì xin mời các thầy cũng ở lại để giải đáp các cái câu hỏi của
thầy giải đáp anh Hòa.
Chắc chúc bác sĩ Vũ sẽ quay lại để chiếu cái angio cuối cùng cho mọi người xem, cũng như là chắc là show lại cái IVUS cuối cùng. Dạ em mời thầy Bình tiếp tục ạ.
Okay, we continue the CME now. What do you think about the case, Dr. Huang? Yeah. Majority of us choose a provisional stand, but Dr. Wu to do a DK crush. What do you think about this procedure?
I think Dr. Wu already prepared for that. So everything you prepare carefully, the result will be better. So it's okay for the patient. For me, I think I similar to Professor Bing from the very beginning. We try to keep everything simple because for the future patient, like usually came back when he's older, and then we still got a more chance to work with him later on. So as long as we do the PCI, I think that I try to keep it as simple as possible. So I still prefer that the provisional stenting. However, I have to say that everything you already prepare carefully, then the outcome should be better. So just follow the plan. Yeah, I think.
Thank you. How about Dr. Tân? Yeah. What do you think? I think majority of us choose provisional stand, but you and Dr. Wu choose a DK crush. What situation you choose a DK crush for the patient? For example, maybe stenosis at the audio of circumflex, or 5 mm from audio to the circumflex. We can do the DK crush technique.
Yes.
Yes.
Yes. For this case, you can do 1 stand or 2 stand. Depend doctors, depend experienced doctors. I think for me, I think only keep for biphasic reasons, keep it may be better. So must for me, but depend on the other doctor, I think.
Yes, thank you. How about Dr. Tân?
Maybe I and Dr. Wu have the same point. So in this situation, we based on the IVUS information from the proximal circumflex, from the optimal to the proximal circumflex, maybe heavy severe lesion. So and the distal left main in IVUS measure, we have done anyway about 0.0 centimeter. So I think this situation, decay crust or mini crust, sometimes we can do some technique in this case. So provisional stent technique, I think we also do provisional stent technique from the left main to LAD. However, after stenting, we will reveal less from the lesion of the ostial LCS. But the first time we measure the lesion, ostial lesion of circumflex in the IVUS, we can find some severe lesion and the deep field lesion from the ostial circumflex to proximal, especially in the before stenting mid circumflex. So in this case, Dr. Wu, maybe it's a true dedicated technique. And today we want to show the IVUS in complete BCI. So in this situation, Dr. Wu should dedicate us to show technique to everyone to know about this. I think so.
Thank you, Dr. Ji Phương. One question for you. When we do the first kissing, you use normal balloon or NC balloon?
In the first kissing, I use the NC balloon in the membrane side branch, and maybe the bigger balloons in the membrane. In this case, if I use maybe 2.75 NC balloon in the L6 and maybe 3.5 NC balloon in the left main LAD. Because if I think stand in the left main LAD, maybe we can choose the bigger stand with the 3.5 stand.
Thank you. And Dr. Wu, so you have a final result already or not?
Yeah, I just checked the IVUS for the final. Yeah, this is the IVUS for circumflex. This is the IVUS for circumflex after standing. Yeah, you see it's well expanded into the vessel wall. Vessel wall is about 2.75. Yeah, this top. Yeah, okay. This is the
LED.
Left man now.
Okay. Đây là cái lỗ xuất phát của em. Không phải. Đó, ok, rồi, đây nè, đó lỗ xuất phát đó. This is the circumflex ostium is about 6. Anh khoan chiếu lại đi nó. Yeah, it's about 6. Anh khoan coi thân chung. Coi cái thân chung. Okay, yeah. Cái nhỏ nhất, cái này là hơi lớn. Cái nhỏ chút xíu, cái chỗ nào nhỏ hơn. Okay, and hold on. It's about 11. Okay.
Yes, 11 is very good. Huh? In the old criteria, we just more than 8 is okay, but now the new criteria maybe bigger than 10 millimeters square is the criteria, new criteria for the left man.
So this is the LED cho cái vị trí 8-9 giờ nó qua ngoài. It's about 6.5 or 6.6 maybe. Yeah. And ông khoan coi lại thân chung, cái đo lại thân chung. Cái đo đi. It's about 11. Yeah, it's the same. Yeah, okay. Anh khoan coi lại cái lỗ xuất phát LED lại đi. Khoan ngược lại chút xíu. tới chứ. Đó là Y đó, đó là vô thanh chung rồi. Không có, nó cái rìa nó phải rõ. Qua bên trái chứ, qua bên trái cho nó rìa nó rõ mình mới đo được. Nhớ đi con. Ok, đó. It's about, I think it's okay. The final result, I think it's about cái này cũng khoảng 6,6, còn hơn chút. Okay, so I finished the procedure. Final shot.
About 7 better.
Yeah, LD is awesome about 7. Shock awesome about over 6, a little bit, and left man about 11. I think it's good enough.
Okay, show us the final angiogram.
Qua đây trước lên đầu. Qua bên lên đầu. Can you see the picture of the angio?
Not yet.
Okay, on that.
This is TV view, and this is the IO caudal view.
Show us the aerial caudal.
Yes. Yeah. Okay. I think it's good. We have dissection of the left man. I think it's good enough. Okay. Thank you very much for the case. For taking the case from UMC.
Thank you, Dr. Vũ, and thank you, China staff of the UMC DSA. So, Professor Nguyễn Ngọc Quang, what do you think about the final result? We see some dissection at the left man. We leave it like this, or when we do something more.
I think the result is quite fine. We already see the dissection before the stentings, and we already cover everything by the stent. So I think result is acceptable. Now the question is how we choose the DAPT, and I think for this kind of complex case, maybe long DAPT is required for this kind of patient. The other thing is also need to pay attention is to lowering the LDL cholesterol as low as possible for the long-term result. Yeah.
Yes, thank you. How about the comment from Dr. Duy Phương? Do you think that we use DABT for how long for this patient?
I think this we can use DBT with unless maybe 1 year.
Okay, about Dr. Nguyễn Văn Tân, DBT 1 year or just 6 months because this is not the ACS, the CCS patient.
Because in this situation we have a complete BCI, so a very high for ischemia, so we should use long-term DIBT for, especially after 1 year we have a stop score. If more than 2, we can use more for this situation because we have a 2 stents in the left main, very important, and very long stent from the occipital circumflex to the distal circumflex. So I think that we use for long term and that for case.
This means that at least 1 year, maybe more than 1 year, maybe longer than 1 year. How about Dr. Trần Hoa? Do you think that we use the DABT for 1 year or longer than 1 year?
I think this patient longer term, 1 year. Yeah, the patient now with aspirin and ticagrelor. So that's after 1 year we can do another plan. But Dr. Me that treatment with the patient more than 1 year. Yeah, but because the patient very high risk thrombosis, stent left main bifurcation, and now the patient is 3 stent. in the coronary.
Okay. So today we have 5 cases, 3 cases from Dr. Soichi, 1 from Dr. Duy Phương, and 1 from staff of the UMC. Very interesting case with a bifurcation and a left man disease. We use IVERT for the 5 cases, and I think that IVERT very important for us when we do the case with a bifurcation lesion. IVERT can help us to assess the lesion, for example, the black characteristics, the angle between the main brand and side brand, the risk of side brand occlusion, etc. So very important for us. I think that we try to have IVERT in our CAT lab, and we can use it frequently for the lab man for the complicated lesion for the patient. I think that majority of us can familiar with this technique. We can use IVERT frequently and easily to assess the lesion and to help the PCI procedure. Thank you very much for Professor Nguyễn Ngọc Quang. You join with us and give us very interesting and very helpful opinion. Professor Nguyễn Văn Tân, Duy Phương, and Hoàng Văn, etc. Thank you very much. And tomorrow we can meet each other again. That's right, Dr. Quang?
Yes, tomorrow we have the regular intervention club. So we see again with the bifurcation and also the IVERT, and we look forward to receive the lecture from Professor Bing as well.
Yes, today I'm very happy to see you, and I think we present the topic and we have opinion, but in English, I think it's the beginning step to integrate with another country in the world. So I think I'm very proud of you. I'm very proud of you to have a chance to exchange our knowledge and experience in PCI. Thank you again, and want to say see you again tomorrow.
Bye bye. Thank you.
Thank you, Professor Wang.
Thank you, Professor Bing, and everyone. Bye bye.
Chào thầy.
Bye bye.